Welcome to this video on mechanical ventilation in the emergency department, based on key emergency medicine textbooks. Indications for ventilation include failure of oxygenation, failure of ventilation, need for airway protection, and anticipation of a deteriorating clinical course, such as in severe trauma or septic shock. Maximize oxygen reserve before induction by denitrogenating the lungs. Maintain PEEP using a high-flow nasal cannula or NIV during the apneic period of RSI. Transition to the ventilator immediately after tube confirmation. Initial ventilator settings include a tidal volume of 6 to 8 milliliters per kilogram of predicted body weight. Set the respiratory rate to 12 to 16 breaths per minute. Start PEEP at 5 cmH2O and FiO2 at 100%, then rapidly titrate FiO2 down. The primary mode is often assist control volume, or ACVC, which guarantees minute ventilation. Alternatively, assist control pressure, or ACPC, limits peak airway pressures and may offer better gas distribution in heterogeneous lungs. For the obstructive patient, like those with asthma or COPD, the main risk is auto-PEEP. The strategy is to lower the respiratory rate, use high inspiratory flow, and target an IE ratio of 1 to 4 or 1 to 5 to allow for full expiration. For restrictive patients with ARDS, lung protective ventilation is key to prevent ventilator-induced lung injury. Use a low tidal volume of 4 to 6 milliliters per kilogram PBW, higher PEEP, and allow permissive hypercapnia, keeping the pH above 7.20. Monitoring peak and plateau pressures is essential. Plateau pressure reflects alveolar pressure. Keep it below 30 cmH2O to prevent barotrauma. Post-intubation management involves positioning the head of the bed at 30 to 45 degrees to prevent VAP. Prioritize pain control with analgesia and decompress the stomach using an orogastric tube. Troubleshooting high pressures is simplified using the DOPES mnemonic, covering displacement, obstruction, pneumothorax, equipment, and stacking. For stacking, disconnect the circuit to allow full expiration. Non-invasive ventilation, or NIV, particularly BIPAP, is first line for COPD exacerbation and acute pulmonary edema, reducing mortality. Always reassess within 30 to 60 minutes for signs of failure. Thank you for participating in this medical education video. You can reach the consultant and educator, Dr. Nasser Hassan, using the email shown here. Here are the sources for some of the images used in this video. And here is the source for the remaining image.